The webinar will begin in 5 minutes. Okay, so welcome everyone. I know that people are still joining, but we're going to go ahead and get started. So welcome to the third part of the webinar series on concussion, overview and update, hosted by the Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Sherrod, and I'm the Associate Dean of the Office of Lifelong Learning Physician Learning Program. Our office is committed to providing reliable updates and resources for clinicians, researchers, and everyone committed to addressing the challenges related to concussion. So we, Natasha, if you want to advance the slides, perfect, thanks. We would like to acknowledge that we're on the traditional territories across Canada today of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So for those of you who've not joined our webinars before, just a few words about logistics. If you have questions for our panelists today, please put them in the Q&A section of the environment that you can see on the bottom part of your screen. The chat function should be used if you have questions regarding technical difficulties or related to L3 programs or services. When you're asking a question, please upvote questions that are similar to yours, as sometimes we have large volumes of questions and we can't necessarily guarantee that we can respond to all of the questions. We will be sending out a recording of the webinar as well as a Pearls document with the resources that our speakers have compiled next week. It'll be sent via email to all of those that registered. All of our recordings can actually be found on our lifelong learning website. So if you're unable to make a session and you're really interested in something, please look there. There's a lot of great recordings that are available to you. With regards to credits, Main Pro Plus participants may earn certified credits after today by completing a linking learning exercise, which you can find in your Main Pro environment. For Royal College, Main Pro, the credits can be completed by completing a personal development activity, and you can use the My Lifelong Learning Plan tool. So if you have would like to have more information for that, you can see this QR code here, and this is a way that you can, through your own improvement, get certified credit. This activity is per se has not been formally reviewed by the CFPC or Royal College for the educational piece, but it is eligible for non-certified credit. So joining us today, we have Dr. Connie Lebrun and Terry de Freitas. We're very excited to have some of our colleagues here from U of A with us. And they're going to be sharing with us options for patients with concussion symptoms when they don't resolve, among a number of other interesting topics. So Dr. de Freitas is an associate professor in the Department of Family Medicine and the Faculty of Medicine and Dentistry here at the U of A. She's the medical director of the Glenn Sather Sports Medicine Clinic at the U of A. Dr. de Freitas is currently the Chief Medical Advisor for Taekwondo Canada and the Edmonton Combat Sports Commission. She was part of the medical core team for Canada at the Tokyo Olympic Games. Terry was recently invited to the South Korea Kinesiology Conference, speaking on persistent post-concussion symptoms in athletes. Dr. Constance Lebrun is a professor in the Department of Family Medicine here at the U of A. She's a consultant for sports and exercise medicine at the Glenn Sather Sports Medicine Clinic. Her practice focuses on care of musculoskeletal and medical issues of physically active individuals. She attended medical school at McGill, University of Montreal, and completed her sports medicine fellowship and master's degree in exercise physiology at the University of British Columbia. Her thesis examined the effects of menstrual cycle and oral contraceptives on athletic performance. Her academic interests include health considerations for active girls and women, so the female athletic triad and relative energy deficiency in sport, as well as return to play issues, especially concussion and support. So she's a committed collaborator in concussion research studies from the Sports Injury Prevention Research Center at the University of Calgary. So thanks so much to both of you for rounding out our third webinar and bringing your expertise. And with that, Terry, I'm going to turn it over to you.
Thank you so much, Denise. It's a true pleasure and honor to be invited here today. So I'll see if I can share the slides. Here we go. Okay, so we're focusing on when symptoms don't resolve. and what are our options for patients with concussions. We've already done a presentation about that. In terms of disclosures, I do have a small grant for concussion research here at the Glen Sather Sports Medicine Clinic. Other than that, I don't have any other disclosures. So we wanted to start with a case and make this as practical as possible. So the scenario is you're a community family physician, and this is one of your patients, and you know them well. She was away for soccer scholarship in the US and is now home for the summer. Fourth-year midfielder, which means she's very busy on the field. University soccer team, and was injured in a preseason game exhibition, age 21. She says she was trying to head a ball, was hit by the goalkeeper, as sort of like this picture demonstrates when you have an aggressive goalkeeper. She recalls having dizziness and headaches. She was confused immediately after the impact and could not remember how she was injured for about 8 hours. It's now 3 months later. She was cleared to play 8 weeks ago, and she's never returned to being a starter player. And she now complains of headaches, fatigues, and her marks are going down. So as the family physician, the player obtained clearance to play from a walk-in clinic, and she failed to mention her symptoms. She saw the doc and didn't think her symptoms were enough to report. And this happens quite often in some of these athletes. The mother says the coach told her she's not playing as much because she hesitates and did not play the same way she did before. And when faced with this situation, it can be quite challenging for a single clinician. And I didn't add this in the text, but as a family physician, when you see her, you get the, just by interviewing, you get the sense that something's very different. She's behaving a little bit differently. She looks sad. She looks different than what you've seen from before. So is this persistent post-concussion symptoms? So the definition varies quite a bit. So persistent symptoms lasting 3 months after a diagnosis of concussion is one definition. And the general criteria is there's a hit or a concussive force. And then the core symptoms being headache and balance, dizziness, fatigue, sleep, light sensitivity, mood disturbance, and they persist beyond the expected recovery. And the number of weeks and the total number of days is the controversy right now. The other part of the definition is these symptoms aren't explained by another comorbid condition or another condition. So this can be very complicated trying to sort out, and it does help if you know the patient well as the family doc. So in working through this kind of definition, they tried to come up with some different ways. So the first criteria is they had some symptoms, they had a mild traumatic brain injury, and then you cannot account for the symptoms through another mental disorder. So such as, they previously had mood disorder, they previously had anxiety, they previously had depression. And then you look at what kind of an impact it has and what was their previous level of function versus what their function is now. And the diagnosis can be done by numerous ways, and we'll talk about those later when Connie goes through her part. So everyone's starting to wonder, okay, 3 months is a long time to have symptoms. And so the medical community and the people that work in the area are now looking at maybe we should address this much sooner. And certainly that's been what clinicians are doing in the area. So some authors are promoting a 2 week, 2 weeks for adults, and then you start looking for PPCS, and 4 weeks for youth and children, because it does take them a little longer to recover. Now, this is not written in stone. It's more of a clinical entity that people in the area have been working with. And of course, we're looking forward to the new international guidelines coming up in June. So the other complication is that it's not one single entity. It's a term to describe a group of symptoms. And what the challenge is in your office visit is, are these due to the concussion itself, or were they there before? And that's the challenge. When we talk about the risks or the rates of post-concussion symptoms, there's in the literature right now, in the pediatric literature, they're quoting anywhere from 1.5 to 15% of pediatric patients with sport-related concussion will develop this. And another recent study in 2020 reported 20% PPCS at 30 days from the concussion. And it does vary a little bit when you look at sport versus motor vehicle accident or bicycle accident. So the numbers are highly variable, and just keep in mind and be alert to the fact that perhaps 1 in 5 of your concussion patients may develop this. There's been lots of ways of trying to figure out, can we predict who's going to actually have this? And the work continues in this area. So we're going to try a little poll. What part of a patient's concussion history increases their risk of developing post-concussion symptoms, persistent post-concussion symptoms? So give it a try. Let's see what you think. And on the final number, it should read D and E in the section G. We'll just give Andrea a minute to calculate the results.
Actually, the poll hasn't come up yet. Natasha is just trying to.
Oh, okay.
Natasha is trying to figure out how to get it going.
Oh, there we
go.
Okay. There's another choice at the very bottom. So there's several choices.
Are other people seeing it come up?
Yeah, I can see it going. It's really good.
Okay, cool.
Yeah, I can see the answers. It's very good. You give it a full minute. It should say, yeah, there we go. Okay, so we're just going to end it at a minute. So, so very good. So there's a bunch of symptoms in here that are all important. When we're talking about PPCS, the actual answer is female sex and headache at emergency department. Now I can't move there we go. So I wanted to show you this because it's important to be aware of the two sets of symptoms. So when you look at the red flags, those are in the acute phase, and they are associated with the potential for it being a structural brain injury instead of a concussion. So we take these very seriously in the acute stage, and they usually don't show up much later. So for instance, loss of consciousness, deteriorating conscious state, vomiting, and that set of symptoms, those are red flags that we should really review the patient's exam and then consider the chance that maybe something worse is going on. In contrast, the predictors for the PPCS are several weeks later, you've had a concussion, you're out of the woods for a structural brain injury, but your symptoms aren't just going away and they just keep coming and keep staying with you. And so in order to predict who might be vulnerable to PPCS, so far the stats are showing female sex, headache, a presentation, a history of anxiety or depression, being under the influence of drugs or alcohol at the time of the injury, and an injury that occurred via bike or motor vehicle, and a sensation of numbness or tingling associated with the symptoms. So those are kind of the predictors that somebody might develop this long-term symptom constellation. Good, okay. So that's that part. Now we're gonna ask, so what do you think the most common symptoms of PPCS might be? So we're just gonna do this in the chat because you just type it in if you want. Right, Natasha? And then we'll have a look. I'm not sure everyone's answering in the chat. Let's see. I'm just gonna, while we're waiting, I saw a question in there that's those red flag symptoms surprisingly are not always associated with predicting persistent concussion symptoms, which is shocking, but so far it's statistically not showing that. However, if somebody does have those symptoms, you obviously want to make sure that you understand that this is just a mild traumatic brain injury and not something else. Okay, so, oh, I think the chat's not working. Depression, anxiety, headache, poor concentration. Perfect. Okay, so let's see. So this can be very confusing, and especially when you're in a, oh, now it's working. Good, nausea, vomiting, fatigue. Yeah, the nausea and vomiting tends to be more in the early stages. Good. Okay, so I'm going to show you how we think about this. So when we're faced with someone who's had the symptoms prolonged for several weeks, it can be quite overwhelming to sort out. And so when we're interviewing the patients, we tend to think about all their symptoms in these categories. So they could have any and all of these symptoms. And so the somatic symptoms after concussion tend to be the larger group, with headache being the most common and associated with dizziness. And those tend to be the more common of the somatic symptoms. People will also, of course, they will report the difficulty in concentration, difficulty sleeping, and irritability. So when we're interviewing the patients, if we can address it in these broad categories and try to cover sections of each of these categories, you'll capture the symptoms a lot better. And that's what we're going to try to achieve by explaining how we approach this in a physical exam. The other thing we have to think about is if you're a physiotherapist, you tend to be biased towards, neck-related headache, whereas a family physician might think more frequently about migraines and anxiety in their interviews. So it's important to make yourself more broad and think about how am I going to identify all these problems? And we've certainly all been noticed it ourselves that we have to think about all the aspects of the symptom constellation in concussion. Okay, so I'm going to turn it over to Dr. Lebrun's recording, and then I'll see you back for the wrap up.
Hello, and welcome to the second part of this presentation on concussion care. When symptoms do not resolve, what are our options? Thank you, Terry, for such a good lead into this part that I'm going to be doing next. I'm Connie Lebrun. I'm a physician and professor at the Glen Sather Sports Medicine Clinic. I have also been a member of the core medical team for Team Canada at Summer and Winter Olympics and numerous other multi-sport games, including the Canada Summer and Winter Games, the Pan American Games, and the World University Games. Here are my disclosures. I'm very grateful for the research support grants that we received through the Department of Family Medicine. I'm a member of the Canadian Traumatic Brain Injury Research Consortium and a member of the Canadian Concussion Network. And as mentioned, I work at the Glen Sather Sports Medicine Clinic. I also work extensively with the University of Calgary Sport Injury Prevention Research Center, or CIPRC as it's called. And the biggest project that we're doing is one funded by the NFL. It's a 3-year prospective study of high school athletes in contact or collision sports. The acronym is SHRED, Surveillance in High School to Reduce Concussion. And on the left is a picture of the SHRED-mobile that we can take to different places to do baseline testing, including drawing blood. I was a family physician before I did sports medicine full-time, and you really are the gatekeeper to many things. You will see concussions acutely on the sidelines. If you're a parent or a coach, perhaps, you'll see them in the office, maybe in the emergency room, and you'll also see chronic concussions and be dealing with return to play, return to learn, and return to work problems with your patients. And you're ideally situated to do this. You look after the whole family. And actually, I looked after a whole family of concussed people because they were all in the same car and got rear-ended by a truck. So they, depending on the position that they were in the car, they had varying degrees of concussion that lasted varying degrees of time. But perhaps you feel that you don't know enough to do it. And I'm just going to convince you that you do and give you a few more tools. Here's a quote that pediatricians report that inadequate training on concussion management is amongst the most significant barriers to effectively counseling patients on returning to school following a concussion. So this might be you when you look at your day sheet and see a patient with concussion booked in, but you should allot 30 minutes for a first appointment with such a patient. Either you can do that or your staff can do that. Patients should be rechecked on a weekly basis. And before you actually go into the room to evaluate them, you can fill out the symptom self-report section of the STAT-5, which will help monitor their progress. And I'll show you that in just a bit. In-clinic assessment includes a history of the symptoms, clarification of data points. You might want to do orthostatic vital signs and your neurological exam, cranial nerves, and fundoscopy. We want to know what their current functioning assessment is for work and recreational activities, and maybe discuss their goals: return to work, return to school, return to play, what's their schedule for practices, competitions, etc. And as I mentioned, you may well do the STAT-5 test. Here's a QR code that would take you directly to the document. There's another assessment called IMPACT, which is one of the online neuropsychological assessments. It stands for Immediate Post-Concussion Assessment Test, and it's used extensively in professional and amateur sport. Basically, it's a battery of neurocognitive tests, and if you look on their website, it's actually been FDA cleared, and it's been widely marketed for both baseline and post-injury testing. It measures a variety of different things, and it can help determine if a patient can safely return to activity. Now, for teams, it's most useful if there's a baseline. It depends on your practice if it's useful for you to follow patients with post-concussion symptoms. There is a version that the athlete or parent can purchase online, do themselves, and then have it sent to you. But this does require some training in order to interpret them. What's more important, I think, is serial assessment of symptoms. And this is a symptom evaluation, the front sheet of the SCAT-2, which was a few versions ago of the SCAT-5. And you can see there's 22 symptoms on a Likert scale from 0 to 6, and the athlete just circles where they are at that particular time. If you do just this, each time you come in, the patient fills it out before you see them, you can get a good sense if they're getting better or not, just even from across the room. And at the very bottom of this, there's another area that says, do the symptoms get worse with physical activity or with mental activity? For athletes in with a parent, do you know the athlete well prior to the injury? And how different is the athlete acting now? The SCAT-5 actually has a bit here that asks what percentage of normal the patient feels, and then what would make them feel 100%. So this can help you zero in on the symptoms. A physical exam for the condition can be done as tolerated. We tend to look at the neck range of motion, again, the cranial nerves. We can assess trigger points in the neck. If there's midline tenderness, you might consider getting a set of x-rays. There are other tests like craniocervical flexion test, neck flexor endurance time, and these are often done by the physiotherapist. But the important thing is to document and repeat these at follow-up visits. You might also need to treat the parents. So the parents are sometimes in the way of the referees when they're at the sidelines, and they may either be in the way or helping you when they have their son or daughter in their office. Another test that you might be able to do that you can learn fairly easily is vestibular ocular motion screening, or VOMS. This is a brief test that's clinically relevant. It can be diagnostic of abnormalities. It can give you great sensitivity and specificity, indicate when you should refer people to a multidisciplinary clinic, and indicate when vestibular physiotherapy might be needed. This was designed by a group from the University of Pittsburgh, and this is Physio and Mucha, the article that described it first, and you have that in
I'm looking at you're gonna use the finger. You know, if you have any pain or discomfort, any double vision, blurry vision. Let me know when you start to see double vision. You know, 3 or 4 inches of it.
So there's a number of maneuvers that you can do, and you can see if the athlete's eyes track properly, and you can also see if any of these maneuvers provoke their symptoms. And it's found that abnormal or symptomatic VOMS are present in up to 69% of adolescents after concussion, and they might be associated with prolonged recovery. So even though your athlete gets back out onto the field, they may not be 100%, and this might be a more sensitive way of assessing their recovery from concussion. There is an article called Bare Bones of Concussion, what the sideline orthopedic surgeon needs to know, and it does give a pictogram of how to assess vestibular oculomotor symptoms. And then I'm just going to play this video for you. This is Cody Isaac, who's a physiotherapist who works with us at the clinic and also has her own physiotherapy clinic. She's just demonstrating how you do these particular tests. There's no sound on this first part, but basically she's recording if the maneuvers give the athlete any symptoms. That's the smooth pursuits part of it. So for the saccades, you have two objects, pens or tongue depressors, and ask the athlete to look quickly horizontally side to side and then vertically up and down. So here, this is exacerbating the symptoms. Next, we test near point convergence by bringing an object closer to his nose. You can either do it or the athlete can hold it. And when the object becomes double or blurred, then you measure the distance from that to his nose. Normal should be less than 6 centimeters. And you take the best of 3 tries. Visual motion sensitivity is a measure of how well they can track and keep fixed on one object. And here he's holding an object and he's turning his head quickly to the beat of a metronome and seeing if that gives him symptoms or how the head goes.
Ready? No. Is there? No. Are there? Did it do it again? Okay, this time I want you to hold on straight out.
And you can get a metronome as an app when you.
Ready?
So you can document this and track the recovery. And here's just an example from the University of Pittsburgh Medical Center of the chart that they use. So for the symptoms of headache, dizziness, nausea, and fogginess, they have a score of 0 to 10. They do baseline, and then they do it after each of those tests that I just showed you. Other easy tests in the office, there's the head impulse thrust or hip test, where you hold the athlete's head, turn quickly or slowly side to side, and then suddenly turn it in a different direction. The patient should be able to keep their eyes fixed on your nose. And if they can't, and if the eyes go off to the side and then come back, that's a positive test. With neck range of motion, you do look for limitations, side to side, up and down, and do it actively and passively. Again, I mentioned the neck muscle endurance. There's another test called the walk and talk test, where you're turning your head side to side while walking and trying to recite something. I quite often will just do a tandem gait forwards and backwards. I have the patient do it with their eyes open and their eyes closed. And you can actually do this instead of that other more complicated balance test. In terms of recovery from concussion, you need to focus on sleep hygiene, identify the symptom triggers, prioritize treatment to address the symptoms that they find most functionally limited. Sub-symptom threshold exercise might help. And as I mentioned, physiotherapy aimed at the cervical spine or vestibular dysfunction. And it's always important to prevent them from further injury. Here, this guy's wearing a helmet. If he falls asleep in class, he doesn't want to end up with a head injury. In terms of return to learn or school, we've talked about all these things as special accommodations that can be done, but I wanted to add in a few others, including the use of audiobooks and perhaps an anti-blue light screen protector or cover on their iPhone or glasses. For follow-up visits, especially when you're determining return to school, you pay attention to the symptomatology, their age and school level, their course load, and the amount of rest following the injury. The easiest is just to use those Parachute Canada guidelines that were talked about in one of the previous lectures, because they have a tear-off sheet that has it all broken down in a very simple way for the parent and the athlete to follow. Very important to consider mental health, especially in younger patients. These people have been out of their activity or sport. They've been isolated from their companions. They're not functioning at high level, and they can certainly get into troubles with mental health. There can be a number of persistent post-concussive symptoms, as I've shown here. And Terry's going to talk more about them in a little bit more detail, but you can get them in constellation, or you can get them as a single symptom. And then you could treat it accordingly. So neck pain could go to see a physiotherapist. Dizziness and balance disorders, you could treat just like you do vestibulitis. Mental health disorders, cognitive difficulties, you have tools in your community to be able to do that. And certainly at the PCN, you have kinesiologists who can help with exercise training of people with concussion trying to return to activity. There are other resources online. These were kind of cute. Dr. Mike Evans is a family doctor in Toronto, and around 2012, I think he did this whiteboard Concussions 101 thing, which I could recommend to patients and their parents. And then he's done an update in 2014 called Concussions, What Are They, What to Do? And that is kind of a fun way to summarize it to your patients. So what about our case athlete? Well, she has a positive migraine and neck disability score. On physical exam, she has abnormal near point convergence, and her symptoms were increased when looking up and down. She also had saccades in this testing. She was only getting 3 or 4 hours of sleep. She actually had the impact test done, and her scores here were low compared to her baseline. So basically, what do I do now? I need help. So here we go over to Terry.
Thank you, Connie. Hopefully I can share my screen again. There we go. Sorry for the delay. And I am going to do this. Okay. So thank you, Connie. So now what are we going to do with this patient? You're getting the feeling that this is going to be a bit overwhelming and possibly difficult to manage as a single physician. Certainly you've got lots of findings. And so now we start thinking, I need a team to help me. This is going to be a challenge. So we wanted to draw your attention to the 4 characteristics of a good concussion clinic. Concussion management has popped up all over the country, some with or without evidence-based care. And so this little guide was developed in 2017, and it has 4 simple questions. Does a clinic have a medical doctor? Are the team licensed healthcare professionals? And does the clinic follow up the most up-to-date standards of care? And you can always ask them as well, what tools and tests and recommendations do they tend to use? And that's kind of the buyer beware guideline to referring on for your patient. So the challenge that we noticed when we set up our clinic was, these athletes get their concussion, especially the community athlete. They might go to emerge. They might go to emerge and then leave because they start to feel better and they don't want to wait. They may or may not realize that they should go see their family doc. And a lot of sports teams don't require medical clearance for return to play. And so that was the case where people weren't getting followed. And we wanted to do better by the patients in the community. So we took the concept that we do in professional sport and varsity sports, where there's a therapist, a physio, and a doctor all talking about the patient's injury and how we're going to address it and how we're going to get them safely back. So yes, can we take this model from elite sport and apply it to persistent concussion? We know that there are a constellation of symptoms, and we have a diverse group of health professionals in which to manage these symptoms. So the good news is now in Edmonton and the area, there are a few options for family physicians. The Brain Care Center, Body Restoration Physio has a skilled physios with physiatry. Isaac Physio is their area of focus, LifeMark. And I just put down a few of them because these are the ones that I know have a team-based care and meet the 4 characteristics of a good concussion clinic as listed before. So just to give you an example, when we do our complex concussion clinic that we talk about, we see the patient together with neurologist, physio, and neuropsychologist. And this is certainly a similar model that Winnipeg has, and there's one in BC as well. It's quite complicated. The patient stays for about 2 hours. They're assessed by physio, sport med, neurology together and all in the same appointment. And then the neuropsychologist does some very specific testing on their own. Then there's a team conference and a team plan. So we all get in the room together. We all discuss, you know, the physiotherapist says, I need to treat their neck. And the neurologist said, they have migraine background. We need to address that. And the neuropsychologist might pick up, you know, their concentration isn't right. I'm not sure what the cause is, but I also picked up mood disorder in our interview. So we talk about it and then we try to establish priorities. So we use several tools, and a lot of these tools are common to concussion focused clinics. Often we have to get the athlete or the patient to fill these out the day before, because it can be quite overwhelming, especially if they have a lot of visual symptoms, to fill out all these 10 pages of forms. Of course, we always recommend regular update. We're anxiously waiting for the new guideline to come out in June, because we think that we're going to be changing this a little bit when we get that new guideline. The key to this is follow-up. So sometimes if you don't have a good follow-up plan, the patient, they decide not to go to physio for whatever reason, or they try to push through it, or something happens and they don't, you know, the plan is not achieved. So the follow-up is key. So here's an example of a plan for our athlete that came in to the clinic with these symptoms. So in terms of the category, for this athlete, we took her right out of play. We started working on her neck strengthening and the treatment of the neck. And then she started the vestibular ocular physiotherapy. As a midfielder, it's really key for her to have a strong neck, and females often tend to be a little bit weaker in the neck if that's not their primary sport demand. Cognitively, we had to reduce her course load for this semester and defer her exams. We had to limit her activities for reading, start really slow first few days, and then increase the length of time. And the neuropsychologist would follow up with her on that. We did a sleep hygiene review, and we talked about preparation for sleep right before bed. So we made some modifications to that. We also helped her get some aids such as earplugs and sleep mask. We did talk about medications, but we decided not to in this case. And then key for somebody, this is a high performing person who was intending to go to law school. So very intense on her grades, very important to her to perform well. So we did offer to have meetings with coaches and then delay her LSAT, which she was intending to write. So that's the comprehensive plan that might come out of a team-based concussion clinic. So the important points are, let's look out for it. Post-concussion symptoms in your patients. Really do a deep dive to see if they're truly ready. The red flags You want to look for those in the acute stage, but also be aware of the predictors for PPCS, which are slightly different in a statistical way. And when you're interviewing these patients, include questions about sleep, mood, cognitive symptoms, and anxiety as they're recovering. So you might be able to pick up if they're developing persistent symptoms. And hopefully today you have a little more confidence in thinking about vestibular ocular exam and incorporating it. And then let's know your community resources and how to access them. Build a team, and hopefully you can build a team around you. And this is a lot easier in a big city rather than a rural place, but you can still build a team of people with interest in the area. And with that, I think I want to make sure we have enough time for questions, because hopefully you have lots of questions for us to answer.
Great. Thank you so much, Terry, Connie. That was super interesting. Just to remind everybody, because I know coming from clinic, not everyone was here right at the beginning, please use the Q&A feature on the bottom of your screen to type in some questions. I know some of them have been answered. I think the red flag you had answered on the fly, Connie, for the first question, which I don't know if you want to just read again.
Yeah, is it in the chat or the Q&A?
It's in the Q&A, yeah.
Okay.
Yeah.
So actually red flags like amnesia, for instance, one would think that if you had 8 hours of amnesia, you'd develop persistent concussion symptoms, and it's actually not associated with it, which is shocking to me still. And for years, I was pretty convinced that loss of consciousness and amnesia are high risk factors for long-term concussion symptoms. But it hasn't been shown in the literature to be the case. It's certainly concerning in the first bit. And so we are always alert to it in the acute stage.
I think the second one was a poll. So Roshan was just sharing with us that he is beavering away to form a new concussion clinic, which is exciting, and was just asking about those guidelines. And I think we could include those in the pearls that we send out, the link to those, guys.
Yeah, that's great. If they have a new concussion team clinic, that's fantastic. We need more, and we need more with evidence.
That's perfect. Deb's asking about ADHD, and so how does that play out with athletes or others experiencing PCCS?
Yeah, for sure. They're definitely at risk for developing this, and it's also difficult to decide, is this like a trigger that made their ADHD worse, or is it ongoing concussion? And really you treat it similarly after concussion, but it's always important to really address the symptoms of the ADHD and the concussion together. And that's why we have a team of neurologists and neuropsychologists, because we actually struggle with this as individuals, trying to figure out what is it, one or the other, and most of the time it's a blend.
Yeah. And then I think just there's some questions here which are great. I mean, we learned a lot of different things today that play out maybe in a clinical environment that's a little bit more focused on this, but perhaps just building off what we learned about last week and maybe revising for people who mayn't have been at that. Could you just summarize some of the things that we should really be thinking of in our clinic and for family medicine? And then also just shout out for folks who weren't able to attend the session last week. It was awesome, and it goes over a bunch of resources as well.
Yeah, I think that CAT website is fantastic. It has all the resources there. Parachute, excellent as well. you may want to print off the Rivermead symptom score and use a dash for mood, and then incorporate a simple vestibular ocular screen when you examine your patients to try and pick up the big components. But that CAT website, I was looking at it too. It's got some great resources all there in one go.
Yeah, I was so excited. I immediately added it into our EMR in clinic.
Yeah.
So just encourage people. There's a Pearls document that will be coming out when those videos are all done that you'll receive on that. But it's the concussion awareness training tool online. Fantastic tear-off stuff that we learned about last week from Dr. Babul. So a colleague is asking about any treatment tips for people with lingering prolonged symptoms of 3 years post concussion. Can it be lifelong? So someone with occasional headaches, fogginess, fatigue, overstimulation. How would you approach that, Terry?
Yeah, so we've had some of those patients come in the clinic, and so I think sometimes what we've discovered is it's a mix, and the person's developed several constellations. So one thing we always ask is, okay, so have we really addressed the underlying dizziness or the underlying vestibular ocular thing, or is it still there? We certainly have had patients like that come in the clinic 3 years later. And it is a very specific skill to pick out, and you need a very solid physiotherapist with a lot of good assessment skills to work on that base. And that would be somebody where you're like, what is the primary generator and then the secondary generators of all these symptoms? So one approach as a solo physician, I would say, is perhaps address the main, the worst symptoms first, try to take a deep dive into their causality, considering that they can play off each other quite a bit. So you can still probably sort it out, but it would take quite a lot of effort in a team-based care, and that's the challenge in our system. We're not well funded for team-based care, so you end up as a singular clinician, referring to neurologists and waiting, referring to this person and waiting, without ever getting a chance to really address it. I hope that helps. I don't know if that helps.
Yeah, no, thanks, Terry, because as I understand it too, that there are charges for some of these clinics when they are.
Yeah, so neuropsychology isn't covered by Alberta Health, and physiotherapy is not covered by a lot of, it's not covered by Alberta Health, and it's not covered necessarily by insurance. So there are expenses to it. And I would be buyer beware. Make sure you're going to a solid physiotherapy clinic that has success with concussion.
So just a logistical point for folks, because I know people are gonna have to run to clinic, so we'll keep going right to the hour. But Jenna, yeah, everybody who registered for these sessions, you will receive an email that has both the recording and the Pearls document for all of the sessions. For folks, if there's a colleague maybe who hadn't registered, all of this will also be included on our Office of Lifelong Learning webpage. If you go there, you can actually see all the different sessions that we've put on all sorts of different topics. And those are all there for you to have a look at the Pearls documents, etc. And please give us some feedback. We're really working to try to create those Pearls. Jack, who's on the call, has been beavering away to create those and try to summarize things. So hopefully that'll be of use to you, Jenna. And just actually, there's a question here around immediate post-concussion stuff. That was covered beautifully in the previous session as well. So maybe I'll just refer you to those recordings. So Jean-Pierre has a couple questions about wondering whether or not it's higher level coaches can perform the SCAT and follow-up to help sort of reduce medical follow-up. So maybe getting at how to make this a little bit more efficient on the clinical angle if people aren't working in a team. What would you say to that, Terry?
So we would recommend the use of an athletic therapist, a certified athletic therapist rather than a coach, because they're not health professionals. Some teams or some clubs have an athletic therapist within their entire club system. There are also private athletic therapists that do this work. So I would suggest doing that rather than a coach.
Okay, great. Jenna has a really pressing case, Terry, talking about a person who is not an athlete, older, more than 2 years out from a head injury, some improvements with physio. Most recently, a neuropsych assessment was recommended, but the referral's been refused twice. Trying to figure out how to navigate care. Jenna, I'm assuming that's in Edmonton or in Alberta. But what would your suggestions be therapeutically there, Terry? Probably geography matters, Jenna, if you can stick that in the, oh, you're in rural Alberta.
Oh, yeah, that's, so, neuropsychology testing can be done, but it has an associated cost, unfortunately. And, so you may look to, some of the neuropsychology clinics. There's one opening in South Edmonton. I think it's already open, actually. I'll have to look at the referral. Marty Mrazek has put it together. And then the other thing is to try and get a review of exactly what are the primary symptoms in the case. With these team-based clinics, we can only do it once a month and we can only see about 4 patients in one clinic. So it's really challenging to do this accurate, comprehensive care. So you could also try the brain injury group, and I'd be happy to follow up on email as well and talk about it as an option.
Oh, that's awesome. Yeah. So feel free to reach out and connect with Terry. That sounds like a really challenging situation for that patient. Roshan just is wondering, is there actually a formal accreditation process for team concussion clinics, or is there a move afoot to make one?
Well, there has been a move afoot. I think it's challenging to get into the accreditation process, but yes, I think that would be ideal, because there are concussion services popping up everywhere, some with evidence-based and some not. So that's why that document, the 4 characteristics, was built, just to give a recommendation for people. But yeah, as far as I know, there's no accreditation planned, because, perhaps an endorsement by Parachute Canada would be useful.
So Abida is just wondering about whether or not litigation and increased age at time of injury could be predictors for PPCS. And I guess that gets into other issues, hey?
Yeah, yes. So these were studies that followed patients out of emergency. And I think the litigation piece, perhaps when they were doing these studies, wasn't in a high enough stats piece when they were combining all the different mechanisms for head injury. Certainly, we've all observed that in our private practices as a piece for, not getting recovering as quickly as possible. But so far on these studies, it hasn't been shown to be a predictor.
Okay, and last question goes to Jean-Pierre. We've had such a thanks for being such a stalwart panelist. So he's just wondering about if there's someone who may have a little bit more predilection towards ruminating and being anxious. How do you help provide that support and sort of manage those elements when you're taking care of a person longer term? Terry?
Yeah, absolutely. So we are not adverse to treating the anxiety disorder here within the sports clinic. And in fact, we end up in some cases starting a medication. Because we have the neuropsychologist assessment, we refer them to psychology treatment as well if they have significant anxiety, impairing their ability for recovery. So we do look at all those options, therapy, cognitive therapy, as well as medications. They definitely have to be addressed, or they actually won't improve very, very quickly.
Okay, awesome. Well, I know people are beavering off to clinic and other obligations. So just shout out to Terry and Connie and all of our panelists for the series, and to Andrea, who is intrepid at tracking them all down, and Natasia, who's been behind the scenes keeping things running, and Jack, who's been working on the pearls, and everybody who's participated. So exciting. And just thank you so much, Terry, Connie, for this session. Just really value your expertise, and so much stuff to learn. And it's great that we have colleagues who can, really help us with that, and just so we can do well by our patients, right? And thanks too for the generosity and in helping out our colleague try to navigate for their patient. Okay, guys, so have a fabulous afternoon. Please fill in the feedback. Let us know how you like this lunchtime craziness in the middle of your day. Is this working for you? We're trying to bring stuff in the middle of the day rather than at the end of the day. And really, yeah, thanks a lot, Terry. Okay, ciao, everybody. Have a great day.